I wanted to thank the organizers for this opportunity. As a pulmonary fellow, it's very exciting to learn about the direction of research currently and the success you guys are having with that. It's a simple case of a pleural lymphoma and the diagnostic approach that we used. Um, Basically, a 50-year-old female presented with complaints of right upper quadrant pain, dyspnea, shortness of breath, weight loss, B symptoms that have been going on for 6 months. Interestingly, 6 months before she had lap chole. Medical history was non-significant. She was a smoker with 25 pack years. This was a presenting chest X-ray with uh, unilateral pleural effusion. She had similar admissions times two, which was 3 weeks apart. These are one of these admissions, and that was her CAT scan. 3 weeks apart. You can see normal appearing pleura, no normal appearing pulmonary parenchyma as well. So these were the initial pleural fluids that we obtained. Both were exudative fluids with lymphocytes predominant. The cytology, cultures, everything else was negative. The dilemma was how do we further investigate this? So using the American Thoracic Society guidelines, after a negative, inconclusive thoracentesis, we pursued for a pleural biopsy. In our case, we pursued with VATS with lung biopsy as well as pleural. And this was a pathology that we obtained from there. Just unremarkable. It's had some bronchiolitis, probably related to her smoking, but significant for extranodal marginal zone lymphoma. Also positive for EBV, which I'll talk about in a little bit. These are the pathology slides with CD20 positive cells. Quick word on just lymphocytic predominant, how accurate is pleural fluids for diagnosing malignancy, less than 60%, and these are based on just case series. Other diseases with lymphocytic predominant, using TB, it's very poor, but if you add an ADA, adenosine deaminase, the diagnostic almost goes to up to 90%. Difficult in RA, some people have used rheumatoid factor and ANA in pleural fluids, but again, does not increase the diagnostic approach. This is the World Health Organization classification of the pleural lymphomas. More predominantly, it's the PEL and PAL, which constitute about 90% of the cases. And these are less than 10% of the cases are these low-grade lymphomas. Like I said, EM marginal zone lymphoma, which is pleural-based, is a very rare disease. There are about 11 cases that have been reported so far. I've listed 8 of them. Different treatment modalities were used for these, from ranging from pleural decortication to pleurodesis and even chemotherapy. And I think the most common chemotherapy used was R-CHOP. Disease association, we already know that marginal zone lymphoma is kind of a chronic immune stimulation syndrome. Our patient was EBV positive, and interestingly, the 60% of the cases that have been reported were EBV positive as well. So I don't know if there's a correlation with that. Prognosis based on these case report and case series, 5-year survival is anywhere from 55 to 79%. Quick word on, although in her case we used VATS with surgical biopsy, but medical thoracoscopy, we have since had success in diagnosing a lymphocytic pleural effusion, a very minimally invasive procedure with a very good success rate of almost 95%. I mean, here with it's better than a closed pleural biopsy. And a quick word, this is a study comparing medical thoracoscopy with CT-guided needle cut biopsies, and success rate of almost 95% and upwards. That was it.
So any words of wisdom on managing the pleural effusion in these patients, given it's a sensitive tumor to treatment?
We went ahead with pleurodesis a year and a half post follow-up. She's done pretty well actually after that. So pleurodesis probably is recommended. Our team decided to just observe the patient without any chemotherapy or any aggressive measures. Thank you.